Welcome to the Plant Trainers Podcast, where we're helping people improve their quality of life through nutrition and fitness. And now, your hosts, nutrition and wellness coaches, international speakers, Adam and Shoshana Chaim.
Hey, I'm Adam Chaim.
And I'm Shoshana Chaim, and we are
Propelled by Plants. Today we bring to you episode 345, the Ischemia Trail and Heart Disease with Dr. Shane Williams.
In this episode of the Plant Trainers Podcast, we talk with our favorite local-ish plant-based cardiologist, Dr. Shane Williams. He is on our show for the second time. He was on episode 296, and we went through the basics of cardiology then. And this time we focus a lot more on the Ischemia Trail. You're going to be stunned by the findings of this study. It brings forward the effect of surgery on cardiac patients, but you're also going to be fascinated to hear how it didn't make it out into the media despite the findings. Therefore, it's our job to share this information with you so that you could share it with others, so that people can really make informed decisions about their health. Once again, it proves a plant-based diet and healthy lifestyle is a better choice even for people who are told that they might need heart surgery.
Dr. Williams is a cardiologist practicing in Bracebridge, Ontario. He's lectured at plant-based conferences, hosted many week-long immersion programs, as well as a 10-day plant-based immersion summit in the Caribbean with Drs. Campbell and Esselstyn and other leaders in the field. Dr. Williams considers himself very lucky to have witnessed and continues to witness so many of his patients often completely turning their health around once they learn and implement the scientifically proven optimal nutrition approach, which is a whole foods plant-based diet. He's really passionate about bringing this information to as many people as possible so that they too can become empowered to both safeguard and improve their health. And listen up, because he's got some pretty innovative ways coming forward of how he is doing that. Please share this episode with everyone you know, plant-based or not. This is such important information that is so life-saving. Here it is.
You have a huge collection of recipes, but you never make them. And you never even know what is for dinner. Things seem to kind of get out of control. You do your shopping, you hope that you're getting everything that you need, and then when 4 or 5 o'clock or 6 o'clock comes around, you're still scrambling to figure out what's for dinner. That used to be our life, and then I figured out the perfect system to make sure that everything was in order. I always had all the groceries that I needed, and that I was making nutritious food for my family without the headaches of the scrambles. So we created the Meal Planning Mastery so that I share all the tools that I use here in the Chaim Plant Trainers Kitchen so that you have them to be able to create your own meal plans with your own preferences so that you are organized and life is just that much more simple. So you can find it on our website at planttrainers.com/shop or click the link in the show notes at planttrainers.com.
And now for a moment of gratitude.
Here in Ontario, we have something called Family Day, which is a given long weekend, and it's encouraged to spend time with your family. We did just that. We spent time with the kids. We went away for the weekend, and we really didn't use a lot of electronics other than watching one movie. And we spent time together. We learned a new card game together, and I'm just so grateful for that time that we spent and the effort that we put in to do it.
Yeah, last week was awesome, spending that time with the family. I'm super grateful to just have the opportunity to still be here and be able to watch our kids grow up and be together as a family. It's awesome.
Dr. Shane Williams, welcome back to the Plant Trainers Podcast.
Thanks for having me back. I'm looking forward to our chat today.
Yeah, me too. We're so excited. It was number 296 when you were on last time. So that was quite a while ago as we get closer to 500. Wow.
400.
As we get closer to 400, it is a lot. It is a lot. And when we had you on the show last time, we talked about, the 101s, must know about heart disease, cholesterol, blood pressure, fat, oil, sugar, all of that. So I definitely think that people should go back, have a listen to that, because we really broke everything down so that they could understand what's going on in their body, all of those key words that might even come up again today. And we are going to talk about something
still in the heart realm, but a little bit different today. But before we do you have a moment of gratitude to share with us and our listeners?
I do, not to get all sad and serious on you, but my dad is 92. He's back in Newfoundland. And so we've been going back more frequently recently because he's failing a little bit and probably won't be with us, in a few months from now. And so it forced me to go back and look through some old pictures of my childhood and life and education and everything. And I must say, I came away from a tremendous, sometimes in your busy life, you don't realize that, wow, I've had a lot of amazing opportunities and a lot of beautiful blessings, really. So that was most times when I go visit my folks, I come back sometimes more irritated. But this visit was one where I came back with a tremendous sense of gratitude, realizing that, they did a good job and they worked hard for us kids. And I'm very lucky to have had parents that I had.
Yeah, it's tough because, you want to make the most of the time you have while you have it. And sometimes people don't realize what they had until it's too late. And
until it's gone, right?
Yeah. And I know my stepfather passed last year and it was kind of the same feelings, you don't realize what you have until it's no longer.
You can't pick up the phone and give them a call anymore and so forth.
Exactly. So people listening, just find what you're grateful for and express it and let people know while you still have that opportunity. Yeah.
Well, hopefully what we're going to talk about today is going to be helpful for a lot of people who are maybe in that same situation with their parents and, cardiac patients, surgery, not surgery, lifestyle, not lifestyle. What do we do here? And let's just jump right into the Ischemia Trail and tell us first, before we start talking about that study that's so important that hasn't been all over the news the way it deserves to, just let's break down the vocabulary. What is ischemia?
So ischemia, I think, comes from the Greek, some kind of Greek word, just means not enough oxygen or lack of oxygen. And it's a term that physicians, like in my small groups with our patients, I say, first of all, the rules are medicine uses terms, as you guys will know after listening to hundreds of physicians, use terms that generally have multiple syllables, sound really fancy. And I think it's designed mainly to make the general population feel more stupid than medicine. It's kind of a mind trick. So ischemia just means lack of oxygen. And we talk about it's interchangeable to call it ischemic heart disease. Somebody's getting angina, not getting enough blood flow to their heart, so they've got ischemia. So that's the origin of that term.
So it's not actually the breathing, it's more the transfer of blood throughout the body that's carrying the oxygen.
Exactly. It's at the cellular level.
And we know that
the other thing I wanted to say, and I was thinking about our talk today, even from the other day or before I started, was people talk about coronary artery disease or heart disease. And it's a bit of a semantic, but like I explained to people again, the vessel is where the problem is. That's where the problem is. So in some ways, it's sort of like, it's almost like saying you've got house disease when really your problem is with your plumbing in your house. In the same way. So most people's hearts, before they have the heart attack, the heart muscle itself, which is sort of almost like the piston in the engine, it's working fine. The problem is the gas lines going to the engine, and that's where the plaque builds up and the blockages build up in the coronary arteries. So it's the arteries. So it's kind of a misnomer to call it heart disease. Really, it's sort of like it's artery disease in the heart.
So what's happening is there's buildup within the pipes, right? All of this schmutz is building up within the pipes. That's narrowing the avenue for the blood to be able to get through. So that's one thing. But then there's also the hardening of the arteries as well, and then they don't become as flexible. So how do those two kind of go together?
The hardening of the arteries is sort of like a street term, again, as an umbrella term for the arteries are just not working properly. What we really need to be thinking about, say, in our last podcast that we did with me, the whole idea of fat is a major contributor. I got a friend of mine who's in commercial piping, and he recently wrote me and said, hey, I met somebody at an event who goes to one of your classes, and like maybe we should talk because some of the principles are similar. He's an engineer who has a special product that goes into the old piping and actually can open up plaques in the piping. And I think he flies around the world and makes millions of dollars doing that. There's more money in piping than there is in medicine. But anyway, and he said to me, there's similar principles to, can a plant-based diet open up arteries? And I don't know if he was just setting me up for thinking that, well, of course it can. And the data shows that it can. But I said, Randy, it actually does better than just opening up arteries, because a low-fat diet, which causes opening of the bigger arteries and the plaques in the bigger arteries, they open up, the low-fat diet, more importantly, or just as important, improves the flow in the tiny little cobweb arteries that these bigger arteries are feeding. So the low-fat diet allows the proper functioning and, more commonly, the dilation of these tiny vessels. So if you know anybody in plumbing or in engineering, you almost get the idea before you learn about flow dynamics that blood pressure or pressure in your house tubes or pipes are coming from the pump itself. They're actually not. As long as the pump can deliver any kind of a stroke volume, the pressure, how high pressure is in your pipes, is more determined with how narrow your pipes are. So it's the same way, to an analogy to human bodies, the pressure and or the blood pressure we measure, for example, is not determined by how strong your heart is. Because before I got in cardiology, I thought, oh, God, if you got a high blood pressure, you must have a strong heart. That'd be a sign of a good thing, wouldn't it? But it's actually not. What it is, it means that the heart, when it pumps, it has to sort of pump more uphill to try to drive that blood through a very highly tightened vasculature, normally mediated by too much fat.
Right.
So a low-fat diet does two things. It cleans out your bigger pipes, but it also helps the tiny little flow and vessels downstream at the tissue level, which is really, really important.
Now, if 450,000 people a year were dying because of bursted pipes in the house a year, what do you... There'd be a significant backlash amongst the plumbing association. Yes.
And or in the same way that the reason why I'm so passionate about people learning about this ischemia trial, and by the way, I direct people through this, listening to the podcast and afterwards, to go to an excellent website called Ischemia Trail, ISCHEMIA, ischemiatrial.org, O-R-G. And it's not my website. It's the website that's published by the principal investigator for this ischemia trial out of New York University. One of the principal investigators is a cardiologist, top cardiologist by the name of Dr. Judith Hochman. Great website with all the both preliminary entry criteria for the trial, what the purposes of the trial questions, the design of the trial, and then more importantly, released this past December what the results of the trial was, which we'll discuss. That's a very important website. So the reason why I'm so passionate about people knowing about this is because they do about 500,000 bypass surgeries a year in the United States. About 10% of that in Canada, maybe nearly 70,000 bypass surgeries. And that's important to know because most bypass surgeries are done for exactly the purposes which this trial has examined, which is by that I mean most people are going in to have evaluations for exertional chest pain, and then they have these tests that show multiple vessels narrowed, and they're not one of those people who recently had a heart attack. Because the folks who have a heart attack, if I step back for a second, you take those plaques in the arteries, and as you probably know, heart attack versus angina is in a similar area, but by a very different mechanism. So if somebody has a stable narrowing in their artery, they're getting blood flow through that artery. It's almost like napkin ringed, kinked a little bit, but you can get enough blood flow through there at rest, and then you exert yourself, you outstrip your blood flow, but nothing's breaking off, nothing's unstable, and then you stop your exertion threshold, and then the blood flow resumes to the amount needed and the angina goes away. So it's a supply-demand problem, which is a fixed issue. That's called chronic coronary disease. It's a stable situation. And that's where most people then enter into a bunch of testing that eventually lead for them to have bypass surgery. About 70 to 80% of people who have bypass surgery or angioplasty in this ischemia trial had what we call stable coronary disease. And that's an important condition because that's the number one killer in North America. number one. And number two is a very important condition because it's so important that plant-based eating has been shown to actually be able to reverse that condition and at least basically stop it in its tracks and improve the symptoms from it. So that's the group of patients we're talking about, the people that can also be improved by plant-based eating, which wasn't even addressed in this trial. This was just mainly, do you just take pills or do you take pills plus do you open up the arteries, and is there much difference? So that's some of the issues why this trial is so important for people to learn about, because, spoiler alert, all these invasive procedures doesn't really do much for people. And that's worse than bad news, because all of these procedures are not benign, low-risk procedures. I mean, every time in the best surgical hands, every time somebody's put on a table in an operating theater in Canada and similar numbers in the U.S., for every 100 people who go through bypass surgery, 100 people who are expected to have no particularly high-risk features, they should fly through the surgery, no big deal. About 3 to 5 out of 100 die on the table. So these are procedures that you would only go and put somebody at that kind of a procedural risk if there's going to be a big bang for the buck at the other end of reduction in heart attack, or the people who do survive, they live much longer. You know, that's what the essence of medicine and pills all is for every 100 pills I write, I may harm one person, coupled with, on the flip side, for every 100 pills I write, maybe I reduce 40 heart attacks, which, by the way, the pills are not that good, but just as a numerical example. So that's why we can justify, or how pharmaceutical medical industry driven by pharmaceuticals can justify to say that, you know, hopefully the amount of good we're doing far outweighs the amount of bad. So if you study a procedure and the procedure shows that it does no good for you, then you're worse than at sea level, because you're going to pay a procedure risk for just bringing that patient to the cath lab or the operating theater. So you got to make sure that putting a bunch of people at risk is going to help more than it's going to harm.
Is there a way to kind of know or guesstimate how many people out of those 500,000 surgeries that are happening don't need it or could have been prevented through lifestyle?
Like, I've heard rough estimates, other than now with the result of this trial, which we'll talk about in particular in a moment, shows again, if there's no benefit in any of these patients that were subjected to this, and again, of all the coronary artery disease people who undergo bypass, about 70% of them are for stable disease. Again, people who at rest, they don't have pain, they haven't had a recent heart attack, but every time they climb up that 2 flights of stairs, they get a nagging chest pain and a heaviness that would rest, it goes away. Not to say it's a harmless thing, because there's some people with such severe angina just tying up their shoes or carrying their groceries, they get 8 out of 10 chest pain and their quality of life is horrible and they need to do something about it. But I think this trial shows that we shouldn't be jumping to angioplasty and bypass surgery. What we should be jumping to is immediately focusing on lifestyle, especially optimal nutrition in these people.
I'm just thinking but they're going to surgeons.
Yeah.
Their doctors are surgeons. They're, that's their job. That's their job. That's what they know. And that's their livelihood.
Right. I often say cynically to people, not to back talk surgeons, because I have friends who are surgeons, and they're smart people and they're highly technical, well-trained people, and they're some of the smartest people in the class. They're fantastic people. But that reminded me of something the way Trump would say it. I'm sorry for that. They're wonderful people. But the problem is like I say to people in my class, someone says, I went to a surgeon and I asked if I should have surgery. It's a bit like, yeah, that's like going to an auto mechanic and thinking, should I fix something here? Mm-hmm. No, go on home. Of course, that is what drives their... Right. Now, I've had surgeons in their defense turn patients down, but that's a whole other story. But yeah, that is the current problem right now, is that studies like this Ischemia trial needs to inform how we practice medicine. And one of my concerns, and sometimes you hate when you're right. Right? You predict something sometimes negative and you think, oh, I hope I'm not going to be right. And then you realize, yeah, you were right. Your cynicism was actually well-based, because when I heard this trial come out first, my first thought was, you watch, this is $100 million National Institutes of Health, I think, funded trial with 8,000 people screened, 5,000 people randomized. This is the medical equivalent to like Disneyland in terms of size of, it's a huge trial. And it showed in the end that people who were stable, those who had invasive surgical treatment, did no better than folks who just didn't do anything except for medications. And I thought to myself, that's not going to make the medical profession look very good, especially the cardiology industry. I wonder how that's going to be played in the media. And I was right. It was hardly picked up by any media outlets. The Washington Post, which I think is Trump's second most hated media after CNN, they came out with a headline, something like, recent ischemia trial shows that surgery no better than pills. That's it. Very kind of small little blip on the media radar, but generally it wasn't largely carried very much by media at all. When really, I guess some people might say to you, to be a devil's advocate, well, Shane, what did you want them to say? Well, I first wanted them to kind of have a full disclosure to say that, we've been doing bypass surgery since the mid-'60s. And the man who invented it actually was friends with Caldwell Esselstyn. Talk about an ironic circle of irony, right?
Right.
Rene Favellaro from Argentina, I think he was. And apparently Dr. Favellaro, within the first few years, in some conversations with Dr. Esselstyn too, had said that, this is an exciting new technology to be able to tie someone's, saphenous veins to the front of their heart and temporarily improve the blood flow. But we need to be very cognizant and sober when we evaluate this technology going forward to make sure that, although it looks very high tech and sexy, are we actually doing net good for patients? Or is this just going to be driven by either how interesting it is or how much money it's going to make for heart centers? And I think trials like the ischemia trial was a very sobering reminder that we got caught up in the excitement and in the money of it. And we really didn't soberly look at, in an honest way, whether we're doing net good for people, because this is a very invasive and it kills some people every time you do it. And again, you need to be darn well sure that this is helping people and that you don't just get caught up with a momentum that the heart centers are busy and this is exciting and look how nice we make our stitches and blah, blah, blah. But you got to keep calling yourself back to say, are we doing net good here? And so it was disturbing. But the reason why I think it's important is because people need to know about it, because since the mainstream media didn't talk very much about it, and since medicine is sort of like, oh yeah, meds are pretty good, surgery doesn't offer much benefit, and I don't think they've really done a full sort of confessional about it to say that, well, looking back now for the past 40 years, what does this mean? That we've really been offering almost no benefit for 2/3 of patients who had this very invasive procedure, and we're 5 out of 100 people on the table died because of it. So number one is we're really sorry for having killed so many people. Sorry to use the K word. For having had so many people be harmed unknowingly to us. So let's pretend we're ignorant. But for heaven's sakes, going forward now, this should immediately inform medical practice to drastically reduce the number of people who are strongly suggested to have bypass surgery. Because this is a group of patients that maybe you or your family members or friends were some of these people. These were people where when we evaluated people with stress testing to evaluate chest pain, and they had very abnormal stress testing ischemic results on treadmill testing, and it was very moderate to severe ischemia. Those were the people that and just a few years ago when I used to do on call here locally, those are the people that we would say, whoa, we'll get off the treadmill. Okay, we're going to admit him right now, Friday afternoon, and we're keeping him overnight and over the weekend because Monday morning he needs an angiogram and he's got to go to our local tertiary care cardiac center because he's like, handle him with kid gloves because I'm very worried about this patient. He's a high-risk patient. And he or she would go on to have an angiogram and say, oh, look at all those blockages, and immediately go on to surgery. And I remember hearing lots of patients say to me, oh, yeah, the doctor, as soon as I got the abnormal test result, they were super nervous with me. They wouldn't let me go home. My wife had to bring all my shaving gear. Like, they didn't want me to basically move. And now we know that was not the appropriate approach to these people, that these people should have been told to eat better food and give up the cigarettes and the hamburgers, and that you would have done just as well than if we had put a power saw to your chest. So that's a pretty significant bit of information.
But the doctors are not being taught lifestyle medicine in med school right now. Still, it's getting better, but it's still not the same. And so when a patient comes into a current doctor and says they have all these issues with their heart and pain and breathing, and the doctor tells them that they need to have surgery, the patient says, yes, I do. Mm-hmm. They listen to their doctor. And so at what point is the impact of a study like this going to make on future doctors, but current doctors, that's really going to be helping patients on a bigger scale, especially if they're sweeping this kind of study under the rug to kind of cover themselves up?
Dr. Williams, sorry, before you answer that, if I could just be a realist for a minute, nobody gets to being 100 pounds overweight from 0 to 1 in one. Usually they don't go 1 year time. So they've been told, like, I am so sure that they've been told over the years, you're starting to gain weight. You need to lose weight. You need to lose weight or things are going to get out of control. But nobody's taking, a lot of people are not taking action. And doctors in the past, not every doctor is like William Cardiology, where they're able to give the tools for them to be able to do that. So they've been told year after year after year, lose weight, lose weight, lose weight.
They'll deny.
But they'll be like, they go home, they skip breakfast for 3 weeks to try to lower their calories, and then they go back to normal, right? Like this is what we see with yo-yo dieting. So it gets to the point where doctors don't know how to tell their patients to lose weight, and patients don't know how to lose weight also. Sure. Right.
That's why to answer your question, Adam, is that
I just wanted to jump in here for one moment. Hey patrons, we wanted to give you an extra shout out and tell you we appreciate how much you care. Because of your contributions, no matter how big or small, you've helped us to cover hosting and production costs, as well as give a bright young intern a chance to work with our compassionate company. For those of you who want to help support the show, support learning opportunities for young plant-based students and compassionate causes, you can do so at patreon.com/planttrainers or click the link in the show notes. And now back to the show.
That's why to answer your question, Adam, is that how are we going to get physicians to teach more patients? That's tough because we're all so hyper educated and sometimes hyper egotistical that thinking that what I know is best. Look at all my books and papers on the wall and don't you dare challenge me. And if there's anything important in vascular disease, surely God, they taught me it all in vascular school, which we realize now they didn't. So that's a tough group. That's almost like taking a bunch of Olympic skaters and saying, you're doing it all wrong. We need to teach you right from the beginning. And they'd be like, you can take a short walk on a long bridge or whatever, like you're not going to get much uptake. So I think much the same as kind of our approach. I think the way to do that is to educate the general public, which is like what you're doing too, right. Where you need to basically, like I coach people to basically look at healthcare as another commodity that you need to be an informed consumer when purchasing and when taking advice from healthcare people, and get away from this attitude that my group in Newfoundland, where it's very much of a traditional Catholic authoritarian thing that if the priest said it, if the doctor said it, if the principal said it, nobody ever questioned that. So I'm coaching a lot of people to say, we can't challenge authority. Well, maybe not challenge authority, but you need to have your high degree of skepticism, and you need to think critically about the advice you're being given. And I know sometimes, like, this is overwhelming sometimes for me, and I've got the training in it. So for your general John Q. public who hasn't gone to university or medical school, a lot of the terminology can be overwhelming, and they just want someone who can they trust? And, it's a really significant, overwhelming situation, hence the importance of programs like yours to try and break this down for people who want to go and put the effort in to try to understand it better.
Right.
Thank you. So I want to just make people understand what it is that they can do. So now we have this information that's saying people who will not have the surgery will possibly live a longer life just as sick, or be able to change it through lifestyle medicine and reverse what's going on for the most part and be able to get their life back. So before, when somebody's told you're overweight, you've got cardiac disease, we need to go into surgery now. What are the good questions that people can ask their surgeon or their cardiologist to really weigh and understand if they're in that group that they must have this surgery or they might have days left to their life? Or how do you weigh the scale of, are they going to be one of these oopses, or do they really need the surgery? How do they figure that out?
How I would approach this is that there's a couple of questions related to what the ischemia trial has shown us. So again, without even speaking it in detail, the net result is you got stable coronary disease. There's no advantage to going an invasive approach plus meds versus meds alone. Now, when this trial came out first, in fact, even before I saw it released, a couple of my plant-based patients sent it to me to say, way to go, this is great news. And I was fairly quick to point out, well, it is great news in some ways, but it's also very bad news. What it tells us is that, like, if surgery doesn't make things better, that doesn't necessarily mean things are very good. Because what it showed that both the medicines alone group and the medicines plus surgery group, they both did poorly, meaning that they had recurrent events of, I think, somewhere around 20% at 5 years, just like Esselstyn's trial comparators did in his trial, Treat the Cause, which, of course, he got 91% of people out of 200 people to eat better and dropped his 5-year event rates to less than 1%. So comparable rates in people who just take their meds after a heart attack, they have a 20 to 25% chance of another event at 5 years. So the ischemia trial showed that surgery didn't do much for you, and that if you continue to just take meds and ignore lifestyle, the story is bad. So it's bad with surgery and it's bad without surgery. So I think that's one important message, is that, this is not really it's not really a happy message in many ways. It's a very sad result, really, that all of this money, all of these lives lost, and really we did nothing for these patients. Like, it's very sad. So that's the one thing, is that modern medicine, the best we can do, billions of dollars of treatment, and we're not really doing so great. That's number one. Number two, then, is where Esselstyn's work and people like his work informs us to say, okay, those people then who just take meds or take meds and surgery, in other words, are just treated by standard conventional modern cardiology, they still have a huge area of risk that's not being addressed by the conventional approaches, which I know I'm preaching to the converted, because you both know this and believe this. It means now those 20% event rates at 5 years, you need to really get lifestyle more than ever. Since the surgery is not going to help you, you need to focus on lifestyle more than ever.
So we're not saying that people should avoid the medication if they need the medication. We're saying
no.
So let's clarify what we're really saying. What's the solution for people that are finding themselves in this place? If they're prescribed medication, we're not saying don't take the meds, just change your diet.
Yeah, I often get told, oh, you're the doctor, glad to see you. I heard about you. You're the doctor who takes me off all my medications. And I'm going, no, you got the wrong guy. If you got coronary disease, established vascular disease, or diabetes, you need medications like aspirin and statin drugs to reduce your risk. That being said, by eating better, your doses of drugs like statins, I think, can be responsibly reduced to a much lower dose than you would otherwise need than if you ate very poorly. In the vascular disease patient we're talking about now, we've got people who just have high cholesterol alone or high blood pressure alone and no documented vascular disease. And those truly are the people, if they eat better, could come off all their medications. But in this group of patients with stable coronary disease, no, I would not suggest people to say, oh, celery will make it all better, throw the pills in the toilet. No, that's not what I'm recommending. I'm recommending to stay on your medications, but eat better and get down in the minimum amounts necessary. And you not only then, and by saying no thanks to the stent and the bypass, you're not, an important part of this, you're not being negligent. You're not being reckless by doing so, because those invasive interventions are going to offer you little or no benefit. The only slight benefit that there was in the trial, which I think they massively over-touted, was that, well, people who had an invasive approach with stenting or bypass had slightly better anginal control. That's not impressive to me. Number one is because we know they'll get significantly improved anginal control with lifestyle changes towards a whole food plant-based diet. That's a losing argument. The trials showed that these invasive procedures, for the most part, are destructive rather than beneficial. And then to have a sort of afterthought to say, but those with angina will do better, that's nonsense, because people on a plant-based diet here in the clinic, within weeks their angina improve if they actually come and eat seriously healthy. So we already got angina covered. That wasn't something we're in, the market for. What we're looking for is, are these invasive, aggressive, and potentially lethal surgeries going to save lives, going to reduce heart attacks? And it didn't either.
And so what this study is showing us, for those people that are saying, well, it's too hard for me to change my lifestyle, it's much easier for me to just take the medication and do the surgery, they're not doing themselves any good by going through that surgery. They're not cutting corners and taking the easy routes and getting themselves better, because the study's showing us that there is no improvement.
There's no improvement
coming from doing that.
Yeah, and some people, they need to remember too that bypass surgery has a lot more side effects than is often advertised, including, for example, my father has moderate dementia. It's only one particular case. He had bypass surgery 15 years ago. The data shows that about a third of people following bypass surgery have significant cognitive impairment, memory impairment, and a very significant acceleration in developing cognitive impairment, such as dementia. So that's an area of bypass surgery that in the business, very crudely, we refer to it as, of course, this business has many crude jokes that we don't tell patients about, crudely as
we won't tell anyone.
Don't tell anybody. Known as, somebody says, oh, gee, they're confused after the bypass surgery, and my husband's personality's changed, and he's not interested in me anymore, and he's really cranky, and he's like this now 6 months after surgery. That's often referred to as a condition called pump head. So they have permanent cognitive impairment following all the plaque that's been blown up into their aortas, into their brains after they're put on cardiopulmonary bypass. That's hardly ever discussed by cardiac surgeons to patients when they say, do you want this surgery? And if you do, sign on the bottom line. So that's another dark aspect of bypass surgery that hardly was really discussed. And now that we have the data, and I think it was only tolerated because we were going around thinking that this kind of very invasive and potentially destructive surgery was making people live longer. Even if Bob couldn't remember us, he was at least alive longer. Well, now the data shows that he's not even going to be alive, plus his brain is going to be damaged. Do you still want to sign up for that? Probably not.
So it is because of the surgery, and it's not because of the lifestyle factors or the health factors that really brought them there, and they would have inevitably had those brain disorders anyway.
That's a very good point. The problem is that when you do age match controls of people with similar vascular risk factors, the folks who have the bypass surgery accelerate into dementia much, much quicker than the folks who just have high cholesterol and high blood pressure and eat hamburgers. And
what are the laws around, or how many side effects do doctors really talk about when, they say, oh, you need surgery right away? Legally, you have to disclose all of the side effects that can happen, right? Like there's an X amount of chance that you die on the table. There's this amount of chance that you won't be able to have sex again, what have you. They need to put that out there, don't they? That's kind of a loose kind of a term, though, that they need to legally talk about all the side effects. Admittedly, it'd be like saying, well, technically you're supposed to talk about every side effect with every pill you prescribe. My God, sure, I'd be reading like the articles. We've seen the commercials.
The commercials.
Right? You'd have a list as long as your arm. So most times when we prescribe drugs, we don't say that. We talk about, okay, this sleeping pill might cause you drowsiness. That's why the thing is beneficial. So we mention the big ones, but we generally don't list off all the possible ones. And same with surgeries. I mean, I'm not speaking for all cardiac surgeons, but in my witness of it all, that's not largely discussed at all. The general topics are discussed, like sometimes surgeons will put a number on, your chance of dying here is so many percent, and your chance of having a heart attack or a stroke could be such and such a percent. The cognitive impairment goes beyond the stroke area. So definitely there's, I don't know the number offhand, maybe 2 or 3% chance of stroke with bypass surgery. But what's more insidious is can't remember where the keys are, don't know your wife's name, right? Those are more things, or again, worsening cognitive impairment over the subsequent 5 to 10 years. Those are more insidious onset damage that is definitely more associated with those type of surgeries, and that's almost never mentioned. It's not never mentioned because we didn't know about it. They started bypass surgeries in the 60s. Cardiopulmonary bypass machines were invented around that time, or were available so that surgeries could be done. And more and more patients by the 70s and 80s and 90s were being noted to have significant impairment beyond just not being able to move your arm, not just gross localized stroke findings, but more subtle behavioral, mood, attention, and memory issues, which are tougher to measure, which is one of its problems. They're more subtle and tougher to measure, and then that allows it to kind of go under the radar and allows it to go a lot more undetected. So it's just another one of those things that, hey, this thing that you shouldn't have bought, by the way, here's another 3 or 4 problems with it, why it's not a good choice for you. And that's hence my passion to tell more people about this trial result, because I hope medicine, and I'm sure surgeons being made aware of this, I hope they're more going forward, they're more informed, and they tell patients, so many more patients, that this may not be a beneficial procedure for you, and that let's go back to point zero here and put you on the right medication, or keep you on them, but really look for ways to reduce your risk in other approaches. And by the way, the evolving area of lifestyle medicine and vascular disease work by people like Ornish and Esselstyn is showing some very promising results. Maybe you should take a look at your nutrition. So they're kind of two separate but related issues in terms I hope the conversation is going. That's my hope for medicine. But medicine sometimes is a little tone deaf, blind, hearing impaired to hear their own studies. So as a double, insurance policy, let's inform the general public as a more informed consumer, so that when you go to the doctor and the doctor says, oh, you clearly need bypass. Oh, by the way, you're so sick, we got to admit you over the weekend. You got to, So before they get on with a lot of that trash, I hope a doctor or patients will say, hold on now, is this a beneficial procedure for me? Oh, yes. Why is that? Well, this is how we always did it. Well, isn't there more information that maybe this may not be the best thing? And maybe the doctor will say, well, you're not in that particular category of people because you have certain things that wasn't studied in that trial. And I'd be like, okay, that sounds rational. Show me what you're talking about. And so I'm not saying all bypass surgeries should never be done this day going forward. I'm just saying that for the stable patient who has anatomy of 3 of those vessels blocked, consistent with the inclusion criteria of the Ischemia trial, which is about 70% of people who undergo bypass surgery, most of those people, as of now, should be told the truth, and that this is not going to improve your survival or reduce your risk of heart attacks.
What percentage of cardiologists do you think will know about this trial if somebody says, have you read this trial? Or I read in this trial that this was the outcome. Are you really thinking that I really need this surgery?
I think this did hit the local internal medical media fairly extensively. Okay. So I do hope that cardiovascular specialists will be made aware. Some of them, they're interesting. That a lot of the naysayers, you might guess what their first response was. Their first response was, oh, it's only 5-year follow-up. So Judith Hochman, I'm sure anticipating that response, she said, well, don't you worry. We're continuing to follow all these patients, and 5 years from now, we'll have 10-year follow-up on these 5,500 patients. So this was sort of like, this was like the Star Wars sequel. The first similar trial that was done, called the Courage trial, if people want to learn a bit more background even on the Ischemia trial, was the Courage trial. I think I may have mentioned this to you maybe in the previous podcast or in another show I did, where people years ago, I think this was around 2004 or 2005, where what they did was they took a similar group of people with abnormal stress testing, and they took them, most of them were on meds, or a lot of them were, and they took half of them and gave them medications and invasive stenting, and the other half they left on medications. And the interventional cardiology group who put stents in, they were totally gung-ho that this was going to make all the difference in the world, that definitely the people who got stents we'll do better. It's in the can. No problem how this is going to turn out. Great. It's going to be great for the business of stenting. Well, it turned out in the end to show no benefit of stenting over just leaving the people on medications alone. So the stenting cardiologists back at those times, they were very unhappy. Their complaints were, well, those were using old stent technology. That group there, only 70% of them were on aspirin. If more people were on aspirin, that would have changed the results. Blah, blah, blah. Like it sounded like a political battle of whining over this or that. So I think Judith Hochman, she was a cardiologist back then, and she saw these complaints. So she purposely designed this ischemia trial to make sure that the medical treated people, 90% of them were on the proper meds, that we used all the modern technology generation stents, so they couldn't whine that the reason why it didn't show superiority is because we didn't use the latest version of something. That she really, really crossed her T's and made sure everything was up to date, very well treated, and it still came out 0 in the wash.
This really reminds me of some of the work that Dr. Greger put on nutritionfacts.org with the mammograms, and how women who do mammograms, we're saving 1 in 1,000 lives, but how many are we ruining because we're finding tumors that would have otherwise just taken care of themselves. And, people are coming off work. Parents are getting scared. Families are getting scared. Families are getting torn apart. People are going on welfare because they can't work, and all the money that it costs in the States if you don't have insurance. I believe that doctors want to do good, but if we don't look at the research, they can't do better. Is that kind of where we look at things?
I agree. And we need to be careful that something that on the surface in any one individual patient in front of us who seems like a good idea, that's not a good enough reason to be doing something for 30 years unless we make an honest, objective, sober assessment of something with more technology and looking at unintended consequences, just like the screening well women with mammography. The concept being that, my God, surely got a woman be better off if she knew she had a breast lump. That's a slam dunk. Naturally, you would be better off. And yet when we look at the data, we show that screening all these women and finding breast cancer plus all these other lumps creates so many more invasive procedures, anxiety, expense, procedural complications, killing a few people doing biopsies here and there. In the end, for the one cancer you're going to save in 1,000, it would be better off if you've never known the lump was there, which sounds like almost absurd against this hyper technological world. Oh, it's always better to know. Sometimes it's not better to know.
Yeah.
You only want to know if knowing is going to give you a positive outcome.
Right. There's so much more we can talk about and ask you.
Yes.
I mean, the information is so valuable to us. Just learning from you, we appreciate it, and our listeners, I'm sure, do as well. But before we let you go, because I know that we're tight on time, I wanted to give you the opportunity to let us know what you've got going on, what you've got coming up. I know you're going to be speaking in Calgary, and you have some exciting new medical opportunity that you wanted to talk about.
Yes, well, first I want to put a little plug in for my friends at ForkSmart. They invited us out to Calgary on June 6th to speak alongside one of my mentors and heroes, Dr. T. Colin Campbell. So that's going to be a big thrill for me, and also very stressful because it's only me and him on the bill. So, it's sort of like being asked to come and play your ukulele while Bob Dylan opens up for you. So it's pretty stressful, but it's a big honor. And the same with that ForkSmart event. There's a dual event where on March 11th, Michael Greger is speaking in Calgary as well. So a little plug for Michael because he's doing some amazing work. In terms of our particular clinic here at williamscardiology.com, sound like an advertisement. We just started sort of embracing more online technology. So our plan is to launch. Or just to step back for a second, we've been doing lunch and learn group seminar, counseling and seminar information sessions now here in the clinic for about 7 years. And we have a great response. We cater some food and so forth, and people really like it and like how we present our messages. And we've been asked for years, my cousin or or family member lives in BC or in Newfoundland or somewhere in the United States, I wish you could tape your sessions and kind of get them online. So what we're planning on doing over the next month or so is doing a virtual online lunch and learn educational webinar program. And we think that's going to be quite successful. We hope it is. And we think, a lot of people, that'll be up a lot of people's alley, where I like to think our ability to make sometimes complicated concepts simple and hopefully reduce a lot of stress and anxiety about entering a plant-based lifestyle. And hopefully with my credentials as a cardiologist, we'll give it some weight to people who are been so confused and not know who to trust, that we can talk about the issues, have online question and answer sessions, and just enter into the virtual world where a lot of healthcare is going there. And I think this is going to help us reach a lot more people. And then on that same idea, since I'm a little slow to meet with technology because I'm still paper-based in my clinic, but starting next week, we're just joining the Ontario Telehealth Network, whereby people can actually get a referral to our clinic, and we can then see them virtually online in consult. And I think that'll be a big benefit. I am old school doctor in the sense that, doctors still need to examine patients. And I think for a full cardiac assessment for certain scenarios, people still need to be seen in person, and computers can't replicate that. But there are a large group of people who don't necessarily come to me for my examination skills, although hopefully they're pretty good, but they mainly come to me for information. They mainly come to me to discuss their lab work, to discuss some of the challenges they're having around cardiac issues, and particular plant-based lifestyle issues. And if they just had me for 10 or 15 minutes to go over those key issues, I think I could be a lot of benefit to them. So hopefully this will speed up our ability to see more patients in less time, and also prevent them from having to travel hours and hours. Because we do have people who drive from Ottawa and Montreal and Toronto to come see us, 2 and 4 and 7 hours away. So this is going to hopefully be able to get us to more people in less time, and get answers to questions that people have been dying to ask somebody who's both a conventionally trained cardiologist who also has an interest and some knowledge in plant-based nutrition. So it's please check out williamscardiology.com to find out more, and thank you for letting me do that little plug.
It's very exciting, and I think it's amazing that you're going to be able to reach so many more people. It's definitely the way of the medical future, and we will put links in our show notes at planttrainers.com to your website so people could learn more about you and connect with you for sure.
Thanks a million.
Thank you so much for all the information, and I hope people share it with cardiac patients who they know and doctors as well. Have an amazing day.
Yeah, you too. Bye-bye.
Thank you all so much for listening to this edition of the Plant Trainers Podcast. We want to make sure that you subscribe on iTunes, Google Play, iHeartRadio, Stitcher, or any other podcasting platform.
We really appreciate the feedback we receive from you. Every time we get a 5-star rating or review on iTunes from one of our fans, it really helps other people find us, just like you did.
Thanks so much to our patrons. To become a patron, visit us at patreon.com/planttrainers. Even supporting us with $1 really makes a difference in the quality of the show.
And don't forget to connect with us on Instagram and Twitter. Our handle is @planttrainers. Like Plant Trainers on Facebook, join our newsletter, and check out our website at planttrainers.com for awesome recipes, a list of our services, and of course, our latest podcast.
We encourage you to email your questions to info@planttrainers.com so that we can help you improve your quality of life through nutrition and fitness.
So we hope we've inspired you today. Join us again next time, and have a healthy day. Or is that too corny?
It's a little cheesy.